Good afternoon to one and all. Thank you for coming. I am Dr. Vijay Kumar Sohanlal, a senior orthopedic consultant at MGM Healthcare. We have a team of doctors with a combined experience of almost 40 to 45 years. And today I'm going to talk about how the MGM is prepared when you people reach here with the fractures and with the great difficulties, and how we as a team help you out to go back home happily. So today I'm going to talk what we do in MGM. MGM is almost a 400 bedded hospital. We have around 20-25 bedded ICU and 19 bedded ER. We have in-house CT scan, we have in-house MRI scan, and we have uh, operation theater of 10 theaters in the fourth floor and one emergency theater in the ground floor, which is adjacent to our ER, emergency department. So why I'm giving you this? Because you should know that MGM is a one-stop solution where it can be taken care whatever may be the difficulty you come with. We as a team of doctors will help you out and will treat you and send you home happily. We have around 15 to 20 plus different departments, which when the patient come not only with the fractures, and when they have associated problem like diabetes, hypertension, cardiac problem, neuro problem, so we can even handle that. We really don't have to call any doctor from outside to treat our patient. We have all the departments in-house where each and every doctor is available 24 into 7, where you really don't have to wait for any patient for any cross consultation. So when the patient comes to MGM, so during this COVID time, we have a different access for the patients who come with the fever along with the fracture. We don't deny any surgery or any treatment to them. We take them inside. We have a different floor for COVID positive patients where we treat them so that non-COVID and COVID patients are kept separately. So you can be rest assured that to our greatest effort, we make sure that you don't get COVID positive in the hospital, because we have a different access, separate access for both COVID and non-COVID patients. And we have operated COVID positive patients in spite of knowing that the patient is COVID positive, and we have not denied the surgery to them, thinking that we may get infected. We have put our effort, we have risked our life, and we have treated the patient and sent home happily. When the patient comes with a simple fracture, we have an OPD in the first floor where the patients are screened during because of this COVID time, and they are sent to the first floor where we have our outpatient department, and we take an X-ray. We have a fantastic team, a radiology team, to take an X-ray, and we see what it is. And if it can be treated without a surgery or conservatively and with a plaster, we treat them with a plaster and we reduce the fracture on the outpatient and send patient home. Many places, where they think that, when there is a fracture and then we may go to native treatment, but that is not advisable, because many patients come with a simple fracture going for a native treatment with complications. And that increases the burden on the doctors as well as on the patient in the recovery part. We are 24/7. We work. Even during the difficult times of COVID, we were working. Even if the patient reaches here in the midnight, our team of doctors will come and examine the patient. And if it is necessary, if the patient has to be treated on outpatient department, we treat the patient on outpatient department. We don't think that it is just a simple thing. Why should a consultant go and see a patient at this midnight? No, we do come, we do see the patient, so that the patient feels comfortable that for whatever the reason, he has come in the midnight, because patient comes in the midnight to the hospital only when they have pain, and if they can't be happy. So we consultant come and see the patient, that and then he will be treated and he will be sent home. Before we see the patient, the emergency doctors see the patient and take care of the patient. evaluate and ask for an X-ray so that the treatment is not delayed. That is the entire idea. And when the patient comes with a fracture, where simple fracture where we cannot treat with a plaster or which will require a surgical treatment, then the patient gets evaluated. And then we see whether the patient is having any comorbids like diabetes, hypertension, or asthma. If it is not there, this is a simple fracture. We try and fix that fracture on the same day so that patient do not remain in pain and gets treatment faster and go home faster. Thereby decreases the financial burden on the patient by staying 1 or 2 days more in the hospital. And when the patient comes with, let's say, with the other comorbids, diabetes, hypertension, asthma, which we usually see in a geriatric patients, where when there is a hip fracture, fracture neck or femur, intertrochanteric fracture, those kind of a patients we cannot treat without surgery. They will require definitely surgery. But yes, there is a challenge in the sense not for the as far as the surgery is concerned, but their level of severity as far as the medical problem is there, like diabetes, hypertension. Some may be on some blood thinners, some may be with a cardiac problem, some may be with a neuro problem. So that is the risk, and that is the thing where you have to really work up the patient. You just cannot rush inside the theater unless it is a life threatening, so that operate on such elderly people. So we have to first evaluate with all the blood investigations, diabetes. If they are, then ask for a cross reference from the physician team, do an ECG, chest X-ray, echocardiogram, invite the anesthetist to see whether we can, how early we can operate on such patients. Why early? Because such kind of a patients, the earliest we make them stand and walk, the recovery is faster and the life threatening is less. These kind of a patients, when they come at that age, they are not going to be straightforward patient as the younger age group. They will have to go through some kind of a evaluation, and we have to really work up on such kind of a patients, and we may have to have an ICU backup such kind of a patients where before surgery or post surgery they may require to stay in the ICU for the recovery purpose. If we don't have a ICU as we have it here, then such kind of a patients cannot be treated in such hospitals, because we never know such kind of patients will require some kind of an ICU setup. If we don't have it, then we are lacking. Then that is going to be a trouble. So we are very well equipped with the ICU setup. We have 3 to 4 different ICUs: cardiac ICUs, medical ICUs, surgical ICUs, neuro ICUs, step down ICUs. And during this COVID time, we have a different separate COVID ICU where those patients are treated there even with the fractures. They don't come and get admitted with the non-COVID patients. So these are the things which we are doing it so that patients come and go home with a very good experience. And polytrauma. See, off late when we see road traffic accidents, when the patient is having more than one fracture in any of the limb or the chest or anywhere, those kind of a patients are challenging, because when there is a polytrauma, there will be a blood loss, and when there is a blood loss, his blood pressure, BP will go down, and he may have some breathing difficulty if there is a chest involvement is there. So such kind of a patients, we have a fantastic team where we really don't have to wait or do, because such kind of patients will definitely require immediate attention. We cannot shift the patient from one place to another place, another place to another place. One example I would like to give, where we had one patient who had fractures, almost 45-50 years of old gentleman with a pelvic fracture. Pelvic means the bone which is joining and creating a hip bone and hip joint, and the front part is just above the bladder is called the pelvic region. He had a fracture there. He had a blunt abdominal injury where there was a liver laceration. He had a multiple rib fractures. Along with that, he had a hemopneumothorax and also multiple facial fractures. So if you see in this patient, almost 4 to 5 different departments were involved. One is in orthopedics, one is in a cardiothoracic surgeon, general surgeon, maxillofacial surgeon, and anesthesia. So all these we come into action when such kind of a patient comes, where how to treat such patient, how to make sure that the patient is being well taken care and take him out of life danger position and give him a life which he deserves. Uh, in one that patient, his BP was low, and of course I forgot the urology department just to see whether there is a bladder injury or not. So that patient had a low BP. So we wanted to first stabilize that patient, airway, breathing, and circulation, and then only we plan it. How to go about it. We do a pan CT to see how's the brain was involved, how's the chest is involved, is there any abdomen is involved, so that we don't really miss anything, which in this patient can be very dangerous. Sometimes some blunt injury will not show immediately. It can take 24 to 48 hours, and then that gives a trouble to the patient, and then it can be challenging. So that's why we do all this CT scanning, and if it is required, do an MRI if it is required, and do all the blood investigations. We have an in-house blood bank where we really don't have to struggle to transfuse blood or arrange blood from outside. So we have everything here so that we can treat such kind of emergency patients and send them home happily. We are available 24 into 7, even if it's a holiday, Sundays, or even a national holiday or a state holiday. We work restlessly so that you people can be taken care of. Well, a few of the things which I want to see when there is a lower limb fracture, a femur fracture, or a tibia fracture, a leg fracture. So what we really use it when we operate. When there's a femur fracture, shaft of femur, we use this nail so that it is a very minimally invasive procedure where we don't open the entire area of the fracture. We just open in the upper part and the lower part and send this nail inside. How we do this? We have a beautiful CM which is inside the theater. It is like an X-ray where we see it inside live so that we know where is the fracture and how to negotiate this nail inside. So that such kind of patients with the femur fracture, when we fix this with the nail, we make the patient walk the next day. Many people think that how this patient will walk with the fracture shaft of femur. No, every patient of ours walk on the first day following the fracture, following the surgery, so that he'll be taken care and he'll go home. We have a fantastic physiotherapy department which takes care of a post rehab program where we train them how to walk, how to use a walker for the few initial days, and then walk without a walker, and how to use a restroom, because they all have to get trained before they go home so that they develop a confidence that once they reach home, they should not be dependent on any of the person and they do their own work by themselves. Okay, and sometimes there is a fractures in the leg bone. Again, we treat them with the nail. Nail is a load sharing device which makes the patient walk the next day because it can withstand the weight of the body. We decide whether to make the patient walk full weight bearing or a partial weight bearing with the help of a walker, depending upon how we feel inside the theater while operating. We advise them how to rehab program to be started. So this is what we use it. It is again a small minimally invasive procedure where we just open in the upper end and just the lower end, and we just fix with the 2 screws on the upper end and the 2 screws on the lower end. This all done under CM guidance, where we don't open the fracture area. We just open a small part just underneath the knee joint and negotiate and pass the nail inside and fix it. Sometimes ankle fractures they come. We again treat them when there is a simple fracture. We treat them with the plaster, below knee POP plaster. And sometimes when we think that it cannot be treated without a surgery, then we take them to the theater and fix it with a plate and screw. Many patients do well following such kind of a surgeries because the results are very, very important. That only gives the confidence to the patient that how his life after the fracture and after the surgery, so that he can live his life confidently. And there's an upper limb fractures where shoulder fractures, forearm fractures, or hand fractures. Whenever there is such kind of a proximal humerus fracture, we see in a younger patient also and elderly patients. In elderly patients, they have a fracture just because of an osteoporosis. Just a simple fall or trivial fall in outstretched hand, they'll result in such kind of a fracture in the upper end of a shoulder arm, where if it is required, you can just pass 3 4 screws and fix it. Sometimes that also is not necessary. We can treat it non-surgically. And sometimes when we feel no, it requires a definitely an open reduction and internal fixation, then we fix with this plate and screw. Likewise, fractures in the wrist, where many times when there is a fracture, we treat them without a surgery. The beautiful plasters are available which can be applied, and for 3 to 4 weeks, and patient becomes as normal as how he was before. Such fractures where such kind of a treatment cannot be offered, those kind of a patients we may have to take into the theater and operate and fix it. Those all patients who undergo surgery, they really do well. They're quite happy because we have a fantastic rehab program, and they all feel good that they are uh, recovering fully, and then the hand grip is good and everything. Any questions? If it is there, probably I can take up, and I can probably discuss on those things. We are a center of apart from apart from fractures, we are a center with the knee replacement place where we are pioneered in doing a bilateral knee replacement in a single sitting when there is pain in both the knees where conservative treatment failed, and the patient requires a surgery in both the knees. Such kind of a patients, we evaluate them, we examine them, and we make sure that whether this patient can withstand both the knee replacement surgery and do it. Sometimes we do this when there is a very bad fracture where we cannot fix it with a plate, and then we change it with a knee replacement if it is required. Very few cases we have done, but the option is there. In the hip fractures, when there's an elderly people, when they come invariably with the intertrochanteric fractures, where we can probably use a nail, we call proximal femoral nail. Sometimes other people also do a dynamic hip screw, which is called DHS. We can treat with that, and such kind of patients do really well. When there's a fractured neck, where this is the sternum and this is the femur, when there's a fracture at the neck, just above the intertrochanteric level, such kind of a patients, if it is undisplaced, we can just, those patients will definitely require surgery. Without surgery, those patients will not do well. So when there is an undisplaced fracture neck of femur, we can fix it with just a simple screws and make sure that patient recovers in that. And sometimes that cannot be done, then we may have to replace the ball of the femoral head. In such kind of a patients, we can either do a total hip replacement or a partial hip replacement. So what is the difference between the partial hip replacement and the total hip replacement? In a partial hip replacement, we only replace the ball or the head of the femur, which is at the upper end, which forms the hip joint. When that fractures, and if the patient is anesthetically fit, is not fit, and we have to go fast and come out early, then such kind of a patients we do a partial hip replacement. In that also we make the patient walk the next day itself, and they do well. When there is a patient with a younger age group, let's say 50 55 years, with a fractured neck of femur and is been walking well, so such kind of a patients we would like to do a total hip replacement because the longevity is more and the life of that implant is higher. But it doesn't mean that the partial hip replacement is not better than the total hip replacement. No, it has got its own lifespan, It has got own merits and demerits, and it all depends. The patient's choice is very important at which patient requires what. We cannot offer every patient a partial hip replacement, and we cannot offer every patient a total hip replacement. It all depends on the patient's physiological age, what is their day-to-day activity, what is their demand, and how fit they are inside the theater. So based on that only we can plan which patient will require a hip replacement or partial hip replacement. Okay. Fine. Any questions?
Brilliant. Brilliant.
Right.
Uh,
I think this is what we close it for today, and I wish you a very happy Diwali, and be safe and celebrate your Diwali crackers free, so that we can control the pollution and be safe, and wish you a very happy Diwali. Thank you so much.